and welcome to today's webinar. I am Dr. Regina Davis-Moss, and it is my pleasure to welcome you to Faith and Family Planning. APHA is pleased to bring to you, through our partnership with the Partnership for Maternal, Newborn, and Child Health, another webinar where we explore the issues relevant to maternal and child health. We are pleased to talk to you with the Christian Connection to International Health, where we will hear from different organizations engaging people of faith and family planning program and advocacy. And now I get to you, Dr. Douglas Huber.
Good morning and welcome everyone. I'm with Christian Connections for International Health as the co-chair for Family Planning Reproductive Health. And we are quite delighted with the 5 speakers and the opportunity to share some of the material and the information that's been happening with the faith community with regard to family planning. As you may be aware, there are about 225 million women worldwide who have an unmet need for family planning. And of these, of the pregnancies that do occur, about 40% are unintended, often resulting in unsafe abortions, which cause maternal deaths and injuries. We have been exploring, along with our partners, how this family planning gap can be closed and what is the role of the faith community in achieving this. So today we are going to have presentations from Catholic, Protestant, and Muslim organizations in 4 African countries: Rwanda, Kenya, Zambia, and Cameroon. So, and our first presenter will be Mrs. Marie Mukabasinda from Rwanda. And she is going to be talking about the work with Catholics in natural family planning in Rwanda. So without further ado, please, Marie, would you go ahead and give your presentation? Thank you.
Hi, I am Marie Mukabasinda from the Institute Reproductive Health in Rwanda, working with Caritas, and it's a great pleasure for me to share with you experience of Catholic Church to advance family planning in Rwanda, and I will present just a case study of Caritas. Caritas is a non-government organization created by Catholic bishops of Rwanda in 1960, and it is playing a critical role in family planning in Rwanda because it covers more than 30% of health services in Rwanda, health facilities, and working in different areas: family planning, HIV/AIDS, maternal and child nutrition, malaria. And one uniqueness of Caritas is to lead 60,000 community volunteers working with the health centers just to advance health services. They are providing services, they are sensitization, they are providing information on health issues. So the next slide introduces you to some data on family planning indicators in Rwanda. As you can see, fertility rate decreased from 6.1 to 4.2 from 2005 to 2015. This is good, but not enough compared to our goal to reach 70% of CPR in 2 years. So this is also a gap to try to cover, and also considering that 53% of women are using family planning method, but only 6% are using natural family planning method. this is a gap that Catholic Church are trying to cover. And also, as you can see, we have a long way to do with healthy timing and spacing of pregnancy, because less than 50%, around 50% of women have their children in about 2 or less than 2 years, not have a new pregnancy, not have their birth, but having a new pregnancy at 2 years or less. This is a big gap to cover, and the reason why the Institute for Reproductive Health supported Caritas just to implement an intervention to strengthen family planning in Rwanda. The objective was just to increase information on fertility awareness-based methods, to increase uptake, and also to mobilize the community and to increase the quality of services. So the approach used for this intervention is used in the health system approach and included all those components that training, supervision, data collection, commodity, awareness raising, and also one big component is creating a supportive environment as we are working in natural family planning method. This slide also introduce you to what Caritas have done in this intervention. For Caritas, expanding access to family planning method means offering natural family planning method. But as many of you know, the Catholic Church supports only the use of natural or fertility awareness-based method, while many consider this method to be traditional. Unfortunately, you know with me that there are several evidence-based showing that all those options are effective and are modern. So as defined by WHO, USAID, FP 2020, and other global institutions, Caritas had to work on that to show that all those methods are not traditional, but modern with evidence-based. And they trained community volunteers, they trained providers at the health facility level, and at the health facility level, they provided billings, ovulation method, standardized method, LAM, and 2-day method. At the community level, as community volunteers are new and are still with increasing be familiar with all this method and the environment of the service delivery, they just provided standardized method and LAM. All community volunteers are supervised by providers at the health facility level. Who are community health, community volunteers? I talked community health because now we have at the community level, community health workers, and there are 2 actors at the community level. And now Caritas works with community volunteers. Well, community members selected by the population with integrity, respect, recognized as volunteers, and also willing to work voluntarily because they are not paid, and also farm users. Farm users, because this helped a lot for explaining, for the counseling, because they have been practicing family planning farm for a long time, so that this experience helped them to offer method to the population. This is a short description of the project, and now key results from this intervention. The intervention has been done in 2 years, and now they are in a third year of intervention. And what have we learned in the 2 years of intervention? You can compare the baseline and results from year 1 and year 2, and you can see immediately an increase, a big increase for farm uptake. An example of lamb, as you can see, baseline year 1 and year 2, there is a big increase, but also two-day method. Two-day method has been offered for the first time at the facility level, Caritas facility level, and now you can see that there is a big contribution. And for standardized method that always offered, there is not a big difference between year 1 and year 2, but a big difference between the baseline and the 2 years of implementation. This is a big achievement because if you can see in the next slide, the contribution of community volunteers. Again, if you compare year 1 and year 2, you can see how family planning, farm uptake increased year 1 and year 2, and the contribution of community volunteers are also big compared to the baseline. Now, the next slide introduces you to the evaluation of the quality of services. What are the competence of providers? So the Institute for Reproductive Health has developed a knowledge improvement tool to help supervisors to support providers, and they use it, they apply it. After that, they just refresh them when they have difficulties. Results show a variation method by method and the level of service delivery point. For instance, when you consider services at the facility, you can see that at the facility level for LAM, for SDM, providers are competent. And also, if you go at the community level, they are also competent, because now a provider is considered competent if he or she has a score more than 75%, and except two-day method or for other method, providers shown a great competence. Now, Caritas did a great job because it faced some barriers, it addressed some challenges, and the big barriers they met in the implementation is reporting. Reporting, because at the community level, community volunteers don't have capacity of reporting, to go regularly at the health center without means of transport to go for reporting, and this has been challenging, and providers at the health facility level tried to address that challenge with organizing a meeting each month with community volunteers. But another key issue here is that until now, Caritas tried to advocate for including farm into HMIS, but until now, some methods are not included in HMIS. The next is also the quality of services, because Caritas working with community volunteers, it's a new team, new actors who needed regular supervisions to support the quality of services, but it has been sometimes difficult because of transport, because of it required some main things, main logistic that Caritas really missed. And the third, perhaps I could tell this for the first barrier, because it's very big until now. Caritas is struggling. Caritas and other Catholic Church organizations are still struggling with this bias against fertility awareness-based method. They think that always providers and some actors think that fertility awareness-based methods don't work and are traditional. You got an example or data, so that they have to work on this. They are fortunate because there are some facilitating factors at the national level with the Ministry of Health. The government and the Catholic Church leaders are committed to work closely to advance family planning, and there is a strong community health strategy, including all actors, community health workers, and community volunteers, and all health centers supervising all those community actors. And also we have a national FP strategy, which really value access to the wide range of family planning, not exclude fertility awareness-based method, but include all the range. And also we are working on involving men. This is the principle. And also Caritas is present at the community level. From the lesson learned is that now Caritas needs to regularly refresh providers, also continue to scale up community volunteers because their contribution has been a lot, and continue the advocacy to increase that in HMIS, but also to continue the collaboration with the Ministry of Health. Now, to conclude, three take-home message is that the involvement of FBO is critical to meet global unmet need for family planning, and including farming. The method mix can help FBOs to participate meaningfully to advance family planning. And finally, bringing services to the community level led to dramatic increases in family planning uptake. Thank you very much for your attention.
Thank you. Thank you, Marie. Now we're going to move from Rwanda to Kenya, and Mrs. Jane Kishorian is going to give us a presentation on working and training religious leaders to work with community health workers to increase the demand for family planning. Jane has been working with a Christian Health Association of Kenya for 6 years as a project manager, including projects funded by the Gates Foundation, Packard Foundation, and Bread for the World. Jane also has a master's degree in public health with a focus on international development from Virg University of Amsterdam. Jane, please go ahead.
Thank you so much. I welcome you for this great privilege to present the work of Christian Health Association of Kenya. And I hope we will go together as I make this presentation. Wow.
I think you can go ahead, Jane.
Yes, I'm loading it now. Yeah. So
it was up a minute ago.
Yeah.
There we go. Thank you.
Go to the next slide.
Jane, the slides are up now. Go ahead, please.
Yeah, okay. I'll introduce Chuck. And Christian Health Association of Kenya is a national faith-based organization of Protestant churches, health institutions, and programs from all over the counties of Kenya. And Chuck was established in 1946 and is dedicated to promoting universal access to quality health care. The vision of Chuck is quality health care for all to the glory of God. And the mission is to facilitate provision of quality health services through health system strengthening, innovative health programs, trainings, advocacy, and partnership as a witness to the healing ministry of Christ. The CHWs membership, we have a membership of 576, and this includes the hospitals as stated on the slide. We have health centers, we have dispensaries, churches and church organizations. We have community-based health programs, and we also have medical training colleges and universities. Some of the reproductive health and family planning indicators, as you can see from the slide, Kenya has really made a stride in the reproductive health and family planning indicators, and the fertility rate as per the Kenya Demographic Health Survey, comparing 2006 to 2009, and the KDH's 2014, you can see like the fertility rate was at 5.4, now it's at 4.2. The modern contraceptive prevalence rate was at 46 in 08, and now we are at 58%. Infant mortality rate has also gone down, and also we are also very much interested in the children under 5 years when we are talking about exclusive breastfeeding, which has actually gone up and improved, as well as the children receiving all the basic vaccines. The goals of the project is to increase maternal and newborn and child health outcomes in Kenya. And as you can see in that photograph, we work with religious leaders. We also work with the community health volunteers. And we made some IEC materials like the lessons that they are having. And this is just to make the community aware of family planning. So you can see they are putting on some lessons on themselves. And when they go to the market or when they are doing their community work, people are actually aware who they are for identification and also to spread the message to the community. The objectives, one is to increase capacity of local faith-based health facilities to advocate for and offer improved reproductive, maternal and newborn child health and family planning services, and also to improve the policies and also to improve the resources for reproductive health and family planning. Our second objective is to establish and disseminate a faith-based advocacy model for policy change and resource mobilization to be used by Christian health associations and also the faith-based organizations. And this is to advance the goals of Family Planning 2020. Our main activities in these projects, one is to capacity build the healthcare, the community health volunteers. Number two is to sensitize the religious leaders to champion family planning and reproductive health, maternal and child health. Our third main activity is to increase supply of commodities and services and create and sustain demand for services, advocate for resource allocation, and disseminate lessons learned when given an opportunity. In capacity building, we've managed to train 546 healthcare workers on basic emergency obstetric care and long-acting family planning methods. And in sensitization of the religious leaders, we've trained 250 religious leaders on evidence-based benefits of reproductive health and family planning and the client referral. Our religious leaders are actually very active in giving messages and referring clients to the health facilities. They also work closely with the community health volunteers, especially for the commodities that can be offered at the community level. And as I said, they share information in open dialogues with the community, and this helps to increase demand for services. And as you can see, we are working with all religions. And we're asking ourselves, why engage religious leaders? And one, in Kenya, over 90% of people subscribe to the religion, and the religious leaders command respect and trust. They have a captive audience every week, and they are deeply committed to the well-being of the community, spiritually and physically, and they have prophetic voice in challenging unhealthy practices in society. So they are very important in our family planning advocacy. Increasing supply of commodities and services, we've trained 150 volunteers, and they are trained to issue or to offer family planning services and commodities at the community level. And we also, the community health workers and religious leaders also create and sustain demand. And religious leaders, community health workers are community people. So we believe that there is sustainability even when the project ends. They continue working with the community and offering services to the community. Advocacy for resources. We've trained the religious leaders on advocacy and media engagement. They actually engage the media, like the TVs and the radios. And they also conduct meetings with the county level, at the county level with their governors and Ministry of Health. And this is to ensure that the health facilities, the faith-based facilities get commodities from the Ministry of Health. The religious leaders and church staff have also had some interviews in the radios in English, and also one live TV show in one of the vernacular languages where our projects are. And this was just to meet a wider audience for family planning. Achievements for the last 3 years. The clients referred to the health facility for family planning methods by religious leaders were more than 52,000. We've had 97 new family planning acceptors in 10 facilities, and the religious leaders has reached about 768,000 people with family planning messages. And therefore, we've had improved family planning uptake and improved method mix, as well as improved support for family planning commodities from the county health departments, which CHWs works very closely with. We've had our own challenges, as much as the project have been very successful. We've had staff turnover, especially the staff which have been already trained. You get them moving from one place to another. We also have cultural and religious biases against contraceptive, and that is why we are putting the religious leaders and community health workers on the look and at the community level to ensure that these cultural barriers are dealt with. Occasional erratic supply of commodities and limited basic equipment in some of the health facilities. And at times we have inadequate skilled personnel, especially on the long-acting methods. And of course, inadequate funding, because we only meet very few healthcare workers or health facilities. As you can see, we have a very wide facilities, so we are not able to go to every facility. Way forward, we will continue building capacity through training and mentorship. We'll address see the myths and misconceptions in the community, and we continue strengthening data collection and reporting, and we continue advocacy with the county government, stakeholders, and donors for more resources to reach more faith-based health facilities and communities. I want to acknowledge our partners, our donors, that is Gates Foundation, and who we work with very closely in the Eastern and Central region of Kenya. Foundation, we are in Nyanza and Western region. Bread for the World, and Bread for the World supports us all over the regions. I want to really thank the CCIH for their commitment, Ministry of Health and County Health Departments, and also our community and health facilities, and especially our religious leaders, healthcare workers, and community health volunteers. I want to thank you all for being there, and I know we have learned something from Chuck, that is Kenya. Thank you so much.
Thank you, Jane. That was very informative. And I should mention that for Kenya, as well as the other countries we've been talking about, Rwanda, Zambia, and Cameroon coming up, that these networks of faith-based organizations provide a substantial portion of the healthcare, and governments recognize this. Now we're moving next to Zambia, and Mr. Nagalande will be standing in for Mr. Yoram Sayam. Mr. Nagalande is the Advocacy Officer for the Church's Health Association of Zambia, and he will be talking about working with religious leaders to influence policy. Nagalande, please.
Thanks a lot. Well, my organization is called Church's Health Association of Zambia. Well, Church's Health Association of Zambia mainly is an organization that is based in Zambia, as you might all know. Church's Health Association of Zambia is a non-profit organization that was formed in 1970. It represents the work that is done by 16 Christian churches. These are mainly Catholic and Protestant churches. So these churches altogether have 160 church health institutes, which we refer to as CHWs, and community-based organizations. So these churches altogether, as a response to health, to promoting good health in Zambia, came up with a secretariat called the Church's Health Association of Zambia to coordinate its work. So altogether, the membership is made up of 44 mission hospitals, 77 rural health centers, 10 training schools, and 29 community-based organizations. So there are altogether 16 churches in health, that is in Zambia. These churches include the Salvation Army, the Zambia Anglican Council, the Pilgrim Wesleyan Church, the United Church of Zambia, the Roman Catholic Church, the Church of Christ, Church of God, Egyptian Orthodox Church in Zambia, Reformed Church in Zambia, Christian Missions in Many Lands, also known as CMML, the Seventh-day Adventist, and the Brethren in Christ, and many others, the Baptist Union Evangelical Church in Zambia. Lastly is the Lutheran Church of Central Africa. So following the London Summit in 2012, there was many commitments that were made by the government of the Republic of Zambia. These commitments, among others, were those that the Zambian government had committed itself to scaling up family planning by engaging or initiating dialogue with religious leaders and church leaders. So the Zambian government is achieving this by an 8-year scale-up plan that was made from 2012, and it's supposed to be achieved by 2020. So they did realize that by working with church leaders and religious leaders, it can be easy to scale up family planning in the country. So that being the case, engagements were made with different organizations, and CHWs being the second largest provider of healthcare in Zambia, whose services account for 50% of healthcare in rural areas and 30% of all healthcare in Zambia in general, and being the partner to the government in in the provision of healthcare, decided to commit itself to ensuring that the government did achieve some of these commitments. And the commitment which has ensured that it commits itself to was that of the government initiating dialogue, initiating dialogue with religious leaders, because the church's response to health in Zambia is mainly a CHWs program. CHWs started its family planning program in 2015. So as we went into this program, the main objectives, I would say, going into these programs were mainly to strengthen the involvement of church leaders in family planning, church leaders being people who've got a big influence on their congregants, on their communities, and there are people who can communicate messages that can be heard. So the other objective was that of contributing to improve dialogue between the church and the government on family planning, and lastly, to advocate for Zambia's pledge to be realized, the pledge that is to scale up family planning by 2020 and to come up with to meet specific objectives. So going ahead, CHWs has been engaging in different programs, and has come up with different interventions from the different partnerships that we've had. CHWs has got an audience at every health meeting that is taking place in Zambia, which is where the Ministry of Health and those stakeholders are gathered. CHWs is always present. So as regards policy advocacy, CHWs has got presence at the Health Sector Advisory Group. That is the biggest gathering of the health sector in Zambia, and it is usually held twice a year. And CHWs usually has got a presentation there, because there are mainly three major players, three groups of players in the health sector. That is the civil society organizations, the cooperating partners, and the government through the Ministry of Health. So at the Health Sector Advisory Group, there are usually 3 presentations, and CHWs is the lead CSO in health, so it does that presentation. CHWs has been having access to these various interventions, such as policy meetings and family planning technical working groups. These family planning technical working groups are usually held every month at the last Thursday of the month. So we usually have those every month. CHWs conducted an assessment at the beginning of the family planning program of the country's family planning policy environment. Mainly, we looked at FP commodities, security, service delivery, and bottlenecks among faith-based organizations to inform our program as we started the program, that is the family planning programs. CHWs has identified and trained religious leaders as champions for family planning. So when we talk about champions for family planning, we are talking about the topmost leadership of each of the 16 churches. So we are taking a top-down approach whereby we work with the leadership of these churches, and then from the leadership, messages and I would say messages of family planning and commitments to implement family planning programs go from the top up to the other congregations, I would say, in their districts, in their provinces, and at the smaller gatherings. The church has also added its voice to structuring its voice and structures in the pursuit of FP 2020 goals. Obviously, among other things, the church, for instance, made it known at the previous health SAG that it was ready to work with different stakeholders in health in ensuring that family planning is scaled up in Zambia. CHWs has established the church's strength and challenges on FP provision and advocacy, and the program has facilitated dialogue between the church and the government. I'm going to make reference to another activity that we've been planning that we're supposed to be having next week, where this dialogue is concerned. CHWs has produced videos also in coordination with the CCIH on church leaders advocating for family planning. These videos have been shared online with different partners. We are still working in developing more videos for the church leaders as regards the work on family planning they're doing. Among other things, there's an emphasis on the youth and family planning. CHWs has conducted radio programs around church leaders and family planning. And the churches have reached a consensus on family planning. Because before, people would always think, no, the church has got or maybe different beliefs where family planning is concerned, but a consensus has been reached where family planning is concerned. The results of the work that we've been doing, the various interventions that we've had, is that the church's voice has been heard, and basing on the work that Charles has been doing with the church, we have been able to be instrumental in the task shifting commitment in Zambia. Currently, there is a task shifting framework that is shifting the responsibility of administering injectable contraceptives to community-based distributors. Currently, a policy has been formulated, trainings are being had in different provinces where task shifting is concerned. Zambia has made really, really great progress. We've managed to advocate for doubling of the financing towards family planning. Although the financing for family planning wasn't as sufficient as we would say, and the doubling for family planning allocation, as much as it was doubled, I would say, the allocation itself isn't sufficient, because you'd find that most of the funding for family planning in Zambia is donor-based, and there is this move to ensure that there is an addition there is an added value from the government as well, and that the allocation is increased as much as it has been doubled. Charles has clarified the church's positions on family planning. We're in the process of producing a booklet on each of the 16 churches' positions on family planning. And as and when different stakeholders want to engage with these churches, they're going to know in what way they're going to work with them where family planning is concerned. Charles has also mobilized the church leaders to talk about family planning in their congregation and also on the media. The results also are that there is an increased capacity of the church to engage on FP 2020 issues. So going ahead, we have had different experiences, and we've learned various lessons where engaging with church leaders as regards family planning is concerned. So we have realized that there is a need to support the church leaders, obviously, where family planning is concerned. And the clergy who take the risk of being the family planning front runners, they need a lot of support from us where capacity building is concerned, technical support, ensuring that they manage to organize and raise up and to organize their meetings, they get the technical support that is needed, and also an input on what they'll be presenting and not what they'll be talking about. We've also learned that there is need to engaging the church leaders requires an institution-wide engagement. So as we've said, we're taking a top-down approach whereby we've talked to the clergy, that is the representatives of the churches, going ahead and basing depending on the progress that the program is going to make, maybe in the next 3 years, I would say, where if we do get an opportunity to implement the program from maybe say 2018 to 2020, we are going to be looking at we are going to be looking at engagement of the clergy leaders, believers, and those leaders at the various congregations. Sorry about that. Sorry, my phone just rang. Yeah, so as I was saying, before the full potential of the church can be unleashed on family planning, we need to ensure that we engage everyone at different levels of these church bodies where family planning is concerned. I was talking about the church having an agreement, or rather they have the same position where family planning is concerned. All thanks to CCIH, we have adopted, the churches have adopted a definition of family planning, which talks about family planning being a process which enables couples to determine the number and timing of pregnancies, including the voluntary use of methods for preventing pregnancy, not including abortion, that are harmonious with their values and religious beliefs. So that being the case, here in Zambia, if you talk about the top leadership in any of the churches that are providing family planning, they all have the same definition where family planning is concerned. And where they're engaging with different stakeholders where family planning is concerned, the engagement is on a condition that whatever programs that are being created that any of the partners want to involve with the churches, such programs, such activities need to be harmonious with that church's values and religious belief. and they shouldn't include abortion as an option of family planning. Well, going ahead, as I mentioned earlier, we are trying to have a national engagement where family planning is concerned. There seemed to be a mistake on the entry of the date, but next week on the 19th, we're going to be hosting a very big meeting. It's a breakfast meeting, which is going to bring together church leaders and all family planning stakeholders. That is most of the directors from the various sections in the Ministry of Health, cooperating partners, and the different chairs at the family planning technical working groups, and all members, or just say all players of family planning in Zambia, are going to gather at one place where we're going to have a meeting which is intended to build up on the dialogue between the church leaders and the government on family planning. This is going to be a nice breaking moment whereby, following this meeting, the scaling up of family planning, which is dependent on the promotion of which is dependent on churches promoting family planning, is going to be an open program whereby different stakeholders can engage with churches. We plan on conducting more radio programs and TV programs which will feature church leaders talking about family planning. We also plan on producing and sharing more videos on social media, and also that we're going to televise on our national televisions and different local television stations, which will bring to the fore that Zambian church leaders are for family planning. And
Nagalande, could we go ahead and wrap up since we have 2 more presentations? Thanks very much.
I'm even done. This is my last slide. So Charles will share the FP positions of all the 16 churches in a booklet that we will be publishing. That was a timely reminder. Thanks a lot. I think generally that was my presentation.
Thank you very much. And just to make a point for those of you who are participants and you wish to ask a question, please enter it in the chat box and we will take as many of those as we can at the end. So next up, we are going to hear from Mr. Mustafa about quality families for Muslim leaders in Kenya, perspectives on these, and Mr. Mustafa Ismail is coordinator for the Kenya Muslim Youth Development Organization. So please, Mustafa, go ahead.
Thank you, ladies and gentlemen. Am I heard properly?
Yes.
Okay. Kenya, I'll be doing a presentation on Kenya Muslim Youth Development Organization on perspective on quality family planning, families, and reaching Muslim leaders. Presentation seems to have hanged. Sorry. I'll be doing a background on what Kenya Muslim Youth Development Organization is. Kenya Muslim Youth Development Organization is a national youth-led Muslim youth organization that engages in health program to improve the health of Muslim, mainly youth, women, and families in areas of HIV and AIDS, adolescent sexual reproductive health and rights, family planning, TB, malaria, maternal, newborn, and child health, and ending GBV violence through partnership with state and non-state actors. Our vision, we are envisioned to have a healthy, empowered, and informed Muslim populace. Our mission as KMYDO, we do exist to build the capacity of the Muslim population, mainly the youth and women, to advocate for a human right-based approach in the provision and access to health services within a supportive religious framework. Our objective as an organization is to enhance a right-based approach in addressing key health issues facing Muslim youth and women. 2 is to build and develop the capacity of the Muslim youth and women to be proactive in accessing appropriate health services. And 3, also to strengthen inter networking for an enhanced capacity and understanding of KMYDO mandate. Going direct to the next slide on the specific issues, perspective of on quality families and reaching Muslim leaders, our introduction and how Islam takes family planning and how Islam take family define quality families as a family that has the ability to provide basic needs, education, healthcare, and equitably to all the children. And again, Islam is concerned on the quality of life. And that's why we as an organization, CHWs, we are concerned on how to enhance the quality of life, because we do understand all those changes that are related to prenatal and antenatal care, which are so severe to the baby. Okay, pardon me. Technical hiccup, sorry. Okay. Thank you. Okay, I'll start from the top. Kenya Muslim Youth Development Organization. We were invited to speak on the perspective on quality families and reaching Muslim leaders. The background of the organization, we as Kenya Muslim Youth Organization is the national youth-led Muslim youth organization that engages in health program to improve the health of Muslim, mainly youth, women, and families in areas of HIV and AIDS, adolescent and sexual reproductive health and rights, family planning, TB, malaria, maternal, newborn, and child health, and ending GBV through partnership with the state and non-state actors. Our vision is to have a healthy, empowered, and informed Muslim populace, and our mission is, as CHWs, we do exist to build the capacity of the Muslim population, mainly the youth and women, to advocate for a human right-based approach in the provision and access to health and to health services within a supportive religious framework. Our objective as an organization is to enhance a right-based approach in addressing key health issues facing Muslim youth and women. 2, to build and develop the capacity of Muslim youth and women to be proactive in accessing appropriate health services. And 3, to strengthen and intra-networking for an enhanced capacity and understanding of CHWs mandate. Going direct to the topic.
Mustafa, we can see the slides, and the current one is perspectives on quality family.
Okay. Going direct on those, on the topic, on the perspective of quality families and reaching Muslim leaders. As an introduction, Islam referred to quality family planning as a family that has ability to provide basic needs, education, and healthcare equitably to all the children. And again, Islam is concerned with equity, with quality of life, and that's why we as an organization are concerned on how to enhance the quality of life, because we do understand the challenges related to prenatal and antenatal care so severe to the babies and the mother. And our interest here as an organization is to take care of the well-being of the baby and the mother, especially through child spacing. Different faiths, for us, we do appreciate that different faiths appreciate these issues differently. Some prefer natural methods, while others embrace the new scientific methods of family planning. But for us here, our greatest value is to create a healthy conversation on family planning with the communities, with an aim of finding a way out in terms of our main objectives of ensuring the well-being of the baby and the mother, which are the family. Continuation, it is misperceived by few that the core purpose of Islam or the Muslim is to fill the world without the fear of provision. Actually, that has been mentioned in the Holy Quran, but those are just misperception. And again, Islam emphasizes on the following issues, which I'll try to mention very fast. Breastfeeding as being an important aspect in ensuring the well-being of the mother and the child, and which allows child spacing, hence ensuring that there is quality life. And this has been quoted in the Holy Quran, the 2nd chapter, verse 233, and also allowing this biologically, it also allow the mother to rest between the two pregnancies. Also, Islam has emphasized on equity between children, that is the boys and the girls. And again, Islam prefers quality of children over the numbers. It has been narrated by the Prophet, peace be upon him, that the most grueling trial is to have plenty of children with no adequate means. This has been authenticated by our focal imams, Suyuti and Imam Hakim. And again, other medical reasons why family planning is important, because it is used to prevent transmission of infectious diseases such as AIDS and STD. We as CHWs, we try to reposition family planning by seeking to put family planning as a health intervention again, by introducing the concept of birth spacing or child spacing saves lives, based on the principles of health timing and spacing of pregnancies to reduce maternal, newborn, and child mortality and morbidity by using innovative approaches such as obtaining religious consensus on accepted FP services and then promoting access of Muslim to families, to family planning, information and services. CHWs make use of Muslim leadership, especially the religious scholars on the front line in promoting the concept of child spacing, use of Muslim structures, that is the mosques and the madrasas. The madrasas are classrooms in English, in dissemination of information on voluntary family planning services for Muslim women and youth in accessing voluntary services. Our approach as an organization are right-based, are right-centered, and are implemented through learning, interactive, and participatory approach within a supportive religious framework. That is, we've organized various functions which include the stakeholders forums, where we bring all the religious leaders and the state and all important actors that influence in one way or the other the uptake of family planning and have a collective and a fruitful discussion. 2, we do training on family planning, focusing mainly on those frontline people, that is the imam, the malimats, the youth and women. Advocacy training targeted at Muslim scholars, community planning, community family planning sensitization forum, using Islamic calendars. We do appreciate those days that Muslims gather together for events, maybe for prayers. We do use those days to enhance or to provide services and create awareness. We've used multimedia. We've designed and printed and adapted some Muslim family planning focus flyers and brochures. We've also developed costed implementation plans for counties, and as you can see, we've done one for Wajir County, which has one of the highest TFRs and the lowest CPRs in the county. We've done one for Nakuru County, and there is another one that is on the development process for Kilifi County. And we've also acknowledged some of our partners, being PAI, FP 2020, Save the Child, DSW, and others. Our sustainable approaches that we as CHWs have employed in reaching out on Muslim leaders. We've established Family Planning Advocacy Network, that is the IFPAN. We did identify religious leaders and scholars from national and county level, and also national and county level government leadership, and train them on advocacy on advanced family planning. And the purpose of the entire network is to continually engage scholars on how well to improve the available toolkits and also develop some if there is need be. again, is to engage family planning partners and promote inclusion of Muslim targeted strategies in their work. We understand there have been many strategies, many intervention in the country, but most of them are not sensitive to Islam or to Muslim population, thus rendering the intervention to be less effective to the targeted population. And again, the third function of the network is to advocate for allocation of more resources toward family planning initiative by both government and development partners.
Mustafa, we have one more speaker.
Okay.
So could you please conclude? Many thanks.
Thank you. I'll take you through some of our activities. And as you can see, we've done various focus group discussion. And the photo at the far right of your screen, that is a group of women. We refer to them as the Amina Network. Amina Network is the group, or is as a network of women where they do meet and share all those issues concerning reproductive health and family planning. We've engaged couple at household level through our community health volunteers. We've also done national conference bringing together the entire country scholars, youth representation and leaders. And I'm done. Thank you. Asanteni sana.
Great. Thank you very much, Mustafa. And now we're going to move to the Cameroon. And Mrs. Lily Haritu, who is with the Cameroon Baptist Health Convention Services, is going to discuss with us about family planning integration with HIV services in Cameroon. Lily, please go ahead.
All right, let me try to screen share. This is the one. Can you see my screen?
Yes.
Okay. My God. How do I navigate the slides? Sorry.
Lily, the slides are up. We can see them, so please go ahead.
But I don't think I can move them. In any case, maybe you load the slides you have. Stop sharing your screen. Okay. Okay, I'll be sharing our country experience for the Family Planning and HIV Integration Project. Before I begin, I'd like to say a little bit about the Cameroon Baptist Convention Health Services, which is not quite visible on the slide. The CBC Health Services is a faith-based organization that started over 60 years ago in a small village called Bem. Our goal is to provide quality health care to all as an expression of Christian love. CBC over the years has actually expanded to 6 of the 10 regions in Cameroon. And we presently have, with services that range from village primary health care to specialized hospital care. We have 6 hospitals, 25 integrated health centers, and 50 primary health care centers. We have a large AIDS care and prevention program, of which the Women's Health Program is presently leading family planning services. CIH is in this picture because sometime last year while we were implementing a family planning and HIV integration project, They supported us for contraceptive security through the Cameroon faith-based alliance. And to begin with, we all know that, please, you have to move the slides backward to the background. Okay, thank you. Cameroon has a high HIV prevalence with an estimated 4.3% of the population living with HIV, so our epidemic is actually generalized. Women are disproportionately affected, with the HIV prevalence in this population about 5.6, and in men 2.9%. Studies in sub-Saharan Africa have shown that women who live with HIV desire fewer children than their negative counterparts. And we all know that irrespective of a woman's HIV status, when you address their sexual and reproductive health needs, it will not only give them the agency to control their reproductive health, their reproductive lives, and safely achieve their family planning goals, but it also yields significant public health benefits on maternal and infant mobility and mortality. But for HIV-infected women specifically, of those of reproductive age, increasing access to contraceptive services in particular has the prospect of averting 30% of HIV, the vertical transmission of HIV, than just counseling. But unfortunately, most HIV programs have actually just focused on ARVs, with really no focus on the sexual and reproductive health needs of women. So PEPFAR through CDC piloted an FP integration project in 2 high-volume HIV care and treatment centers in the Southwest region. And we chose, which was the Cameroon Baptist Convention Health Services, which was the Baptist Hospital in Mutengene, and the regional hospital currently serving the Southwest region. Next slide. The goal of the project was to evaluate the change in unmet need for family planning and modern contraceptive usage rate among HIV-positive women of reproductive age attending care and treatment in the Southwest region. The first objective was to determine whether there will be a change in unmet need for family planning among HIV-positive women of reproductive age who present for HIV care and treatment services. The second objective was to determine the change in modern contraceptive usage rate among HIV-positive women who presented for care. Next slide, please. Our project had both an investigative and implementation arm. The investigative component involved the collection of individual level data through the use of surveys and medical abstraction, while the implementation component actually focused on counseling women. And in this counseling, we're not just doing, the standard or regular counseling. We adopted an innovative approach by using population counsel tools. That's a balanced counseling plus, which offers women counseling on a wide range of family planning methods, and then allow them to make an informed decision on which method will best suit them. And we did this by training healthcare providers on the balanced counseling, tools, which involves the use of counseling cards with different methods, with information on different methods, because we wanted to make sure that the information we are giving clients attending care was consistent across two facilities that were implementing this, and that providers were giving their clients accurate information. Training healthcare providers, we also had to renovate and restructure the 2 centers in order to adapt them for FP counseling. So you can see it on this photo, on the next photo. Next slide, please. Yeah, we did this by restructuring FP rooms, because initially, before this project started, care and treatment centers were just rooms where they were dispensing ARV commodities. But for us to integrate family planning into services, we had to restructure this to give space for examinations, to give space for counseling, to give space for one-on-one talk between providers and their clients. The project design. The way the project was designed was, first we had a baseline survey to access unmet need prior to integration. And then 6 months after integration, we still did another baseline survey to access the change in unmet need. And the endpoint survey, we still access which happened 12 months after integration. We're accessing the change in unmet need for family planning 12 months after integration. Presently, we have collected data that is being analyzed. Next slide. Next slide. We have collected data on this, which is currently being analyzed by CDC Atlanta. But we have preliminary lessons which we've learned from integrating this project. First, we realized during the implementation that FP services, the integration of FP services actually resulted in an increased uptake of family planning methods. Here, we're just capturing modern methods of contraception in the 2 facilities that conducted integration. And also, we realized that the provision of FP services within care and treatment clinics, including long-acting reversible contraceptive, was feasible and acceptable to both providers and their clients. Moving forward, we are presently developing a plan to scale up integration of family planning services into HIV care and treatment services, and the CBC will be leading this initiative. And we will have to work with the FPA and the Ministry of Public Health to provide free or low-cost commodities to women with unmet needs for family planning. You remember at the beginning of this presentation, I said CCIH is in this picture because they were actually supporting us as an alliance of faith-based organizations on how we could make commodities readily available to clients who need it. Because doing all of this training, talking about family planning, doing sensitization without commodities will really just take us nowhere if the commodities are not there. So last year, I was delighted to participate in the advocacy strategy which we had with the Ministry of Public Health and UNFPA to see how faith-based organizations can actually have access to their own commodities that can be readily available to their clients. I think when more results come out from this study, we are planning to publish this. We'll be sharing it with you also. Just watch our space on the CBC Health Services website, where we'll be publishing all the exciting things which we've learned through the implementation of this project.
Great. Thank you very much, Lily. We are going to go now to questions, and I believe we have a couple of burning ones that are need to be answered directly. And one was whether all people are served irrespective of their religion, and the answer to that is yes for all the organizations, Muslim and Christian, working in these broad public health contexts. About the methods being provided, Jane Kishorian from Kenya, would you please comment briefly on what methods are provided in the projects that you work on in Kenya, and which ones are most popular?
Thank you so much. In our organization and our health facilities, we offer all methods of family planning, and Depo-Provera is the one which is most popular to most of our clients. And the health facilities are open to anybody, the whole community, whether Muslim, Christian, or any other religion. They are all welcome to the facility, and the facilities are community-based, so they serve all everyone, despite or in respect to their religion. And as I have said, we welcome everyone to our facilities. Thank you.
Thank you very much. There have been several questions about fertility awareness methods, FAM, F-A-M, and there are several good sources for this. The Institute for Reproductive Health at Georgetown University, that is sponsoring the work and working with Caritas in Rwanda, as we heard earlier, has a lot of information on that. There's also a good overall source that we use as evidence-based information, and that is if you Google on Family Planning Global Handbook, this is the WHO USAID evidence-based material that most organizations use and gives a further overview of the fertility awareness methods. I think that if we have other questions, this would be a good time to put them in the chat box. I'd like to ask a question for Marie in Rwanda. Since the Catholic facilities do not provide only provide natural family planning methods or fertility awareness methods, for a woman or a couple that wants another method and a natural method is not suitable for them, how is this handled by the community health workers? Marie, can you hear me?
Hi, Douglas. This is Lauren. Can you hear me?
Yes, please go ahead. Thank you.
Into the camera, sorry. This is Lauren Banning with the Institute for Reproductive Health, and I'll speak on behalf of Marie because she's having some connection issues. That Caritas does provide referrals to secondary posts and public health facilities that are nearby for women who are not able to or do not want to use a natural option.
Great, thank you very much. Sorry we've lost Marie temporarily. It's been a bit of a challenge to have people from 4 different countries signing into this discussion. I think we have come to the time for conclusion, and I would again like to thank the American Public Health Association for their cooperation and as well as Partnership for Newborn, Maternal, and Child Health, and to Christian Connections for International Health for sponsoring this event. As many of you know, that the faith-based organizations are major providers of health information and services, and religious leaders are prominent voices in policy making and advocacy. So if you are inclined to work with faith-based organizations and looking for opportunities, we hope that this today's discussion and presentations will give some ideas about places to start. There is a lot of work to do for all of us, including strengthening the evidence-based information. So if others of you have questions for the chat box, or if one of our colleagues, such as Mona, would like to add a few comments, that'd be welcome at this time.
Hi, everyone. My name is Mona Bormet from CCIH, and while Douglas was finishing, a few more questions came in. So we have a couple more minutes, and I'm just gonna ask one of the other questions. This question is geared towards Yoram at the Churches Health Association of Zambia. Someone has asked, which FP methods are you promoting? Only natural family planning methods, or do you also promote modern family planning methods, including LARC? Angalande, can you answer that, please?
Yes, Mona. We are providing both methods of family planning because there is a collection that both Catholic and Protestant churches that are offering these health services. So where Catholic health institutes are concerned, it's more like a referral point. If they cannot get the family planning method they want from the Catholic health institutions, they're able to refer them to other institutions which are offering other methods of family planning. So it's a mixed method of family planning that Charles is providing.
Thanks, Angalande. Lily, is that the same at CBCHS?
Yes, we are actually providing, we are promoting a wide mix of family planning methods.
And since many of the organizations also work very closely with their ministries of health, these methods are provided to faith-based organizations. But along with this, the training and information for the community are, of course, important for the long-acting reversible contraceptive methods that are now becoming more popular. I believe injectables, injectables and also implants are very popular in a number of countries in sub-Saharan Africa. Wanted to ask Nagalande, with regard to religious leaders and advocacy, do you find any obstacles or challenges in working with religious leaders there? And I might ask that to then other responders, but Nagalande first.
Well, I think the main challenges that we have is if we are coming up with very specific meetings where they all need to be, the challenge tends to be to have all the religious leaders in one place. But when it comes to engaging with a particular religious group, there isn't much of a challenge because, as you might know, our organization is the Secretariat for the Church's response towards health. So when it comes to engaging with them one at a time, it isn't much of a problem. The only challenge comes in with having all of them in one place.
Thank you. And Mustafa, for Muslim religious leaders in Kenya, do you find any challenges working with them?
Thank you, Douglas. For us, I think the challenges are cross-cutting, because for us, we've heard of those religious leaders whom are still extremists, and they are concrete on what they believe in, and they're not like hard to sway. And most of the projects at times, their timeline are a bit short to change the mindset and the perception of various religious leaders whom we do think are going to change the society on our behalf, using the podiums and the when they're doing the congregations. For us, I think the issues are still cross-cutting. We do face challenges when dealing with hard to convince religious leaders, and our focus for us as a young organization, we do focus nowadays, we shift our goals to progressive young Muslim scholars who do understand the issues and do understand, and they are able to link the scientific interventions and those the natural one, and trying to synchronize and find the best method that they can do advocate to the community on our behalf. Thank you.
Great, thank you for that additional point. I should mention that the Christian Journal for Global Health is going to be having a full issue devoted to family planning in different perspectives, both from the point of view of religious leaders as well as programs that are providing family planning services from a faith-based perspective. Would anyone else like to comment on challenges that they've had working in this space of family planning with religious leaders and various denominations in the Christian or Muslim areas?
Yes, I would try to answer that. This is Jane from Kenya, and I've worked with the religious leaders for some time now, and the ones who are trained, actually, they get the facts about family planning, and after the training, they're able actually to know what family planning is, and they're able to go to the community. But there is a challenge when they go now to the community or to their denomination, where we have the other religious leaders who are not trained, actually opposing family planning. But when they are trained, they really get the information correctly, and they become champions in family planning. So information is very important for the religious leaders.
Thank you. I believe we are ready to close now and to give thanks to all of our sponsors, American Public Health Association, the Partnership for Newborn, Maternal, and Child Health, and to Christian Connections for International Health. There will be YouTube availability for the slides shortly after this closes, and I believe there's other information on the APHA website for references and further links for additional information. The Christian Connections for International Health annual conference is coming up at Johns Hopkins University in July 13th through the 15th. So this is a good place for faith-based as well as secular or faith-neutral organizations to get a better understanding broad range of health interventions and programs and approaches that the 150 some Christian organizations that are members of Christian Connections for International Health go about doing their work. It's a great place to network and also to connect with others who may be able to further the work for the Sustainable Development Goals and other aspects that we've been talking about today. Thank you very much. And with that, good day. Until we meet again, go in peace to love and serve.